This is chapter 256, entitled Fetal Surgery for Myelomeningocele by Vijay M. Ravindra and William Whitehead. The objectives for this chapter are to understand the role of fetal surgery in myelomeningocele repair, understand the potential benefits and risks of fetal intervention for myelomeningocele, appreciate the need for a shared decision-making approach in counseling expectant mothers about fetal surgery versus postnatal repair, and to illustrate varying techniques for fetal closure of myelomeningocele. Key concepts include fetal surgery for myelomeningocele, and the recommendations and data thus far are based on the results of a multi-centered randomized controlled trial. Fetuses with myelomeningocele are at risk for losing additional neurological function due to a neurotoxic intrauterine environment, and fetal surgery may prevent this deterioration. In carefully selected patients, fetal surgery decreases the risk of hydrocephalus, preserves lower extremity function, and increases the chances of ambulation when compared to postnatal repair. The surgical goal for fetal myelomeningocele repair is a multi-layered, watertight closure. Fetal surgery is not a cure for myelomeningocele. Combined fetal and neonatal mortality after fetal myelomeningocele repair ranges from 3 to 6% at experienced fetal treatment centers. Fetal surgery increases the rates of pregnancy-related complications, premature labor, premature delivery. In addition, the hysterotomy needed for fetal repair may rupture in the third trimester or in subsequent pregnancies, which is a life-threatening complication. At screening, fetuses with severe ventriculomegaly and lower extremity weakness are poor candidates for fetal surgery because they are unlikely to benefit from the procedure. Despite the benefits of prenatal surgery, postnatal closure remains the safest treatment option for mother and fetus. Prenatal counseling by experienced neurosurgeons is critically important for patients considering this treatment. Early experience. Fetal surgery for myelomeningocele was first reported in 1997. The rationale for investigating this phenomenon was based on the two-hit hypothesis. In addition to the congenital neurologic defects associated with the development of myelomeningocele, spinal cord injury may result from prolonged exposure of the neural elements to amniotic fluid. Muley et al. Reported a critically important paper justifying human trials. This was reported in 1995, where they created spina bifida lesions in fetal sheep and then performed a repair at 100 days using a multi-layered approach. Upon delivery, these sheep had near normal neurological function. The initial experience with endoscopic fetal myelomeningocele repair at Vanderbilt University and University of California, San Francisco were discouraging. Subsequent human studies performed using an open hysterotomy demonstrated superior surgical and clinical outcomes. Between 1997 and 2003, a majority of the fetal myelomeningocele repairs in the United States were performed at Vanderbilt University, Children's Hospital, Philadelphia, and University of California, San Francisco. The Management of Myelomeningocele Study, or MOMS trial, was an NIH-funded study which began accrual in 2003 at 3 centers: Vanderbilt University, Children's Hospital of Philadelphia, and University of California, San Francisco. This trial was unique because all other fetal centers made an agreement not to offer fetal surgery outside of the trial. This was a randomized controlled trial which compared prenatal and postnatal repair. Fetal surgery was performed between 19 and 26 weeks gestational age, and expectant mothers stayed near the trial center until 37 weeks until an elective cesarean section was performed. Postnatal myelomeningocele closure was performed within 48 hours of delivery. The primary outcome was composite of fetal death or infant death or the need for a CSF shunt by 12 months of age. Additional outcomes included an assessment of maternal surgical and pregnancy-related complications, presence and degree of hindbrain herniation, mental development, and motor function at 30 months. Accrual was terminated early due to efficacy in the prenatal arm. At this time, 183 of the originally planned 200 patients had been randomized. The results of the MOMS trial, based on the blinded adjudicated incidence of death or hydrocephalus, was 68% in the prenatal surgery group versus 98% in the postnatal surgery group. The actual rate of shunt placement was 40% in the prenatal surgery group versus 82% in the postnatal surgery group. Motor function at 30 months, hindbrain herniation, and syringomyelia were better in the prenatal surgery group. Children treated prenatally had 2 or more levels of improvement compared to their anatomic lesion level. Fetal, neonatal, and maternal complication rates were significantly higher in the fetal surgery group. There was a higher rate of chorioamniotic membrane separation, pulmonary edema, placental abruption, spontaneous membrane rupture, maternal blood transfusion at delivery. 9% of mothers had a dehiscence at the hysterotomy site. Prematurity was more common in the fetal surgery group, and 13% of fetal repairs were delivered before 30 weeks. The mortality rate in the fetal surgery group was 3%, not significantly different from the postnatal repair group, which was 2%. There were no maternal deaths. Since the execution and publication of the MOMS trial, centers have focused on lowering risk, improving outcomes, and expanding access to care. Despite the positive results of the MOMS study, careful counseling on prenatal surgery should be undertaken and utilize a shared decision-making approach. In 2015, Tulipan published the primary outcomes of the total MOMS cohort of 183 pregnancies. They found that 73% in the prenatal surgery group met the MOMS trial criteria for hydrocephalus or fetal death or infant death versus 98% in the postnatal group. However, the actual treatment rate for hydrocephalus was 44% in the prenatal surgery group versus 84% in the postnatal surgery group. The reduction in the relative risk of hydrocephalus was approximately 25 to 50%. Benefits of fetal surgery. Reduction in the rates of hydrocephalus are thought to stem from the reversal of hindbrain herniation. This stems from the theory described as the unified theory from McClone and Kepner, which is based on the drainage of CSF through the defect in pregnancy, which causes collapse of the vesicles, lowering the posterior fossa volume, creating smaller cisternal spaces, and growth of the cerebellum up through the tentorial incisura. Closure during the second trimester stops the egress of CSF, thus increasing the pressure within the cranium and expanding the skull volume. The effect of fetal surgery on preventing neurogenic bladder remains unclear. Rates of neuromuscular scoliosis, Chiari-2 crisis, brainstem dysplasia with cognitive dysfunction are not known to be affected. The rates of spinal epidermoid and dermoid inclusion cysts and tethered cord syndrome are higher after fetal surgery. The incidence of spinal cord tethering and dermal inclusion cysts occur in 33% of fetal surgery patients versus 10% in postnatal repair. Technical nuances in fetal techniques may influence these rates. There are risks associated with fetal surgery. At experienced centers, the risk of fetal or neonatal death varies from 3 to 6%. The chances of losing the pregnancy are higher with fetal surgery compared to postnatal repair. However, no significant differences in mortality are reported up to 5 years in the MOMS trial. Prematurity and pregnancy-related complications, including chorioamniotic membrane separation, oligohydramnios, spontaneous membrane rupture, spontaneous onset of labor, hysterotomy site dehiscence, and placental abruption may occur. Prenatally repaired patients had higher rates of complications due to prematurity, including respiratory distress syndrome, necrotizing enterocolitis, retinopathy, and infection. Maternal risk should not be overlooked, as there is no direct benefit to the mother from fetal surgery. A 6 to 8 centimeter incision is performed over the fundus of the uterus to access the fetus. However, the hysterotomy required for fetal myelomeningocele repair can complicate future pregnancies. In the MOMS trial, the hysterotomy site was evaluated at the time of cesarean delivery, and over 1/3 of the incisions used for fetal repair were poorly healed and dehisced. Uterine contractions and labor are dangerous after fetal surgery, and future pregnancies must be delivered via cesarean section. Mothers are advised to avoid subsequent pregnancies for 2 years after fetal myelomeningocele surgery. Uterine rupture is life-threatening and can occur in 10% of subsequent pregnancies after fetal repair. Prenatal counseling for fetal surgery and myelomeningocele repair is extremely important. Multidisciplinary efforts by maternal-fetal medicine, pediatric surgery, neonatology, pediatric cardiology, and neurosurgery. Neurosurgeons are pivotal and provide long-term care for spina bifida patients and management of the primary comorbid conditions related to myelomeningocele. Once the prenatal diagnosis is made, all patients should be non-invasively screened for fetal surgery using the MOMS trial criteria. Here we have listed the inclusion and exclusion criteria for fetal surgery in the MOMS trial. Inclusion criteria includes a gestational age between 19 weeks and 25 weeks and 6 days, a normal karyotype, the upper level of the lesion between T1 and S1, and confirmed hindbrain herniation on prenatal ultrasound. Exclusion criteria includes a multiple gestational pregnancy, insulin-dependent pre-gestational diabetes, additional fetal anomalies unrelated to myelomeningocele, fetal kyphosis of 30 degrees or more, a history of an incompetent cervix and/or short cervix less than 20 millimeters by ultrasound scan, placenta previa or placental abruption, other serious maternal medical conditions, i.e. controlled hypertension, obesity defined as body mass index of 35 or greater, previous spontaneous singleton delivery less than 37 weeks, maternal fetal Rh isoimmunization, positive maternal human immunodeficiency virus or hepatitis B or known hepatitis C positivity, no support person to stay with the pregnant woman at the center, uterine anomalies such as large or multiple fibroids or Müllerian duct anomaly, psychosocial limitations, and inability to comply with travel and follow-up. If mother and fetus are both good candidates, then counseling options should include fetal surgery. A shared decision-making model approach should be utilized, which is based on the principle of individual self-determinism. This approach allows patients to participate in decisions about their own care. It recognizes that people have differing needs, values, and risk tolerance, and requires educating patients to make an informed decision. This demonstrates a prenatal counseling algorithm, which is a shared decision-making approach. It involves, after prenatal diagnosis of myelomeningocele, counseling by maternal-fetal medicine, which can result in either a termination of pregnancy or screening from fetal myelomeningocele repair. If the patient meets and mom meet all major criteria for fetal surgery, then they may still terminate the pregnancy or go on to postnatal repair. If they would like to learn more about fetal surgery, then a shared decision-making model of prenatal counseling exists, whereas step 1 is a choice. Patient is informed that there are treatment options and that she will need to actively decide which option is best for her preferences. Step 2, discuss the options, including the risks and benefits of each treatment in the context of the disease. And step 3, make a decision. Patient makes an informed decision based on these informed preferences. Results of this process include either termination of pregnancy, fetal repair, which would require referral to a fetal center for final screening and counseling, or postnatal repair. Throughout all of the process, counseling and education is paramount to success of this model. It's important to identify fetuses who are unlikely to benefit from fetal intervention to avoid unnecessary maternal and fetal morbidity. Post-hoc analysis of the MOMS trial demonstrated that fetal ventricular size, measured by atrial diameter, correlated with the need for postnatal shunt placement. 20% of fetuses with small ventricular size, which is measured as less than 10 millimeters, needed a shunt, versus 79% with large ventricular size, greater than 15 millimeters. The risk of hydrocephalus was nearly 80%, which is the same as postnatal repair. Thus, these patients are unlikely to benefit from fetal surgery. In a similar manner, lower extremity movement at the time of screening also predicts ambulation. Fetuses without lower extremity movement or bilateral clubbing of the feet are unlikely to walk independently after fetal surgery. Thus, a fetus with no lower extremity movement and large ventricles is unlikely to receive any benefit from fetal intervention and should avoid it. The beneficial effects of fetal surgery are significant. However, fetal surgery is not a cure for spina bifida, and not all patients benefit. After fetal repair, hydrocephalus still occurs in 40% of patients, and a majority are not able to ambulate independently. Most patients will need care for neurogenic bladder and bowel, and tethered spinal cord syndrome and spinal occlusion cysts make her at higher rates also. Postnatal repair, which is the standard of care, is safer for mother and fetus and remains a very reasonable option. Surgical technique for fetal closure of myelomeningocele requires a highly specialized team. Anesthesia has to be able to care for mother and fetus simultaneously. Fetal cardiology monitors heart rate and function throughout the entirety of the intervention. And maternal fetal medicine is present to perform ultrasounds, versions if needed, hysterotomy, and fetal resuscitation. Pediatric surgeons are also on hand in case any other complications arise, and specialized scrub and circulating teams are present. This is all in addition to a pediatric neurosurgeon who actually performs the closure of the defect itself. The goals of surgery are to stop egress of CSF from the thecal sac, prevent the exposure of neural elements to the amniotic fluid, protect the neural elements from direct trauma that can occur as the fetus moves within the uterus, and all of these are best achieved using a multi-layered watertight closure. Surgery is best performed between 23 and 26 weeks gestation. General and epidural anesthesia is administered, followed by laparotomy and hysterotomy. The hysterotomy is 6 to 8 centimeters, avoids the placenta, and allows access to the myelomeningocele lesion. If versions are necessary and done, they should be performed prior to the hysterotomy. Intraoperative ultrasound is done to help target the area of hysterotomy and avoid any placenta and minimize trauma to the membranes. Fetus is given an IM injection of fentanyl and vecuronium for additional anesthesia prior to repair. This algorithm demonstrates fetal myelomeningocele surgical closure. The first step is to untether the placode from the skin. Initially, a decision needs to be made if it's safe to cut between the placode and the zona epitheliosa. If it is, then you should cut the arachnoid sharply 2 to 3 millimeters from the placode. If it's not safe, then you should cut the skin lateral to the zona epitheliosa and then trim the zona epitheliosa away from the placode by protecting and lifting the placode and dissecting the skin edge away from the dorsal nerve roots. No placode tubularization is performed. You may consider an onlay patch over the placode to prevent adhesions and add as an additional barrier. The second step is to close dura. If there's thick, robust dura, then a primary dural closure with or without a patch may be performed. If there's not robust dura, then you can close the dura using a combined dural myofascial flap, which will be illustrated in a few slides. If the dural closure is watertight, then you may proceed with skin closure. If it is not watertight, then you may want to augment with a myofascial flap to help seal this in. Skin closure can be performed. If there's a good approximation of the skin edges without tension, then you can perform a primary skin closure. If there's not good approximation without excess tension, then a skin patch, a biparticular advancement flap with relaxing incisions, or rotational advancement flaps may be performed. Primary closure of the defect can be performed with loop magnification. Surgeons must work with the tissue present to achieve the goals of surgery. Dura may be lacking and fragile, and the skin may be widely separated. Fetal myelomeningocele lesions are usually smaller than their postnatal counterparts, and there's less inflammation and desiccation of the tissue, and the planes can be more easily developed. Fetal tissue is also very fragile, and the size of the hysterotomy can limit access. This cartoon illustrates step 1, which is untethering the placode from the skin. This is a cross-section through the placode demonstrating sharp scissors on the left side of the cartoon, dividing the arachnoid between the placode and the zona epitheliosa. Alternatively, when there's little space between the placode and the zona epitheliosa, as depicted on the right side of the cartoon, a knife can be used to cut the skin just lateral to the zona epitheliosa. Then the amputated skin is then lifted and carefully trimmed off the under portion of the placode, and all the while protecting the dorsal nerve roots below. The second step is closure of the dura. The left side of the cartoon here illustrates mobilization and primary closure of robust dura. The dashed lines denote the location of the incision if a myofascial flap is raised. The right side of the cartoon demonstrates mobilization of a multi-layered dural myofascial flap. As illustrated, an onlay patch may be placed over the placode prior to closing this layer to help augment closure and decrease adhesions. The third step is illustrated here, which is including skin closure. Complete multi-layered closure of the myelomeningocele with an onlay patch, dural myofascial flap, and primary skin closure would be ideal. If there's lack of skin, a skin patch can be sewn in, or biparticular advancement flaps can be mobilized medially with relaxing incisions, or a rotational flap can be created. There are indeed surgical nuances and variability with each of the techniques. In some lesions, the skin defect is too large and cannot be closed primarily. Options, again, include a skin patch, bipedicular advancement flaps, or rotational flaps. Bipedicular advancement flaps can be created by making relaxing incisions 2 centimeters lateral to the skin defect. These were employed in the MOMS trial and are allowed to heal by secondary intention in utero and postnatally. After completion of the myelomeningocele repair, the hysterotomy is closed in layers with care taken to close the chorioamniotic membranes. The uterus is refilled with warm, sterile crystalloid solution, and then closure of the laparotomy is undertaken. Postoperative care is focused on preventing preterm labor and delivery. Delivery is performed via cesarean section. After delivery, well-healed myelomeningocele repairs do not require precautions. If there is a CSF leak at birth, it should be repaired early after birth. Fetal surgery for myelomeningocele repair has undergone many innovations and advancements in technique, and this will undoubtedly be the case in the future. Fetal surgery will continue to play a role in managing myelomeningocele until a cure is found. Hysterotomy-related morbidity has led to the innovation of many hysterotomy techniques and fetoscopic techniques. Fetoscopic techniques avoid morbidity associated with hysterotomy and allows for vaginal delivery. Percutaneous port placement still carries a higher rate of pregnancy complications, prematurity, and fetal death. Early results of externalization of the uterus with 2 to 3 port placement has shown promising results, but further study is needed.